Be sure to get 5 to 8 fruit and veggies every day. Today we're discussing osteoarthritis with Dr. Steinberg, orthopaedic surgeon, and Dr. John Baker, physical therapist. It's time to look at the surgical options of arthroscopy and joint replacement. I asked Dr. Steinberg to explain arthroscopy and its role in osteoarthritis.
Arthroscopy is basically a camera is placed into a joint, and in another small incision we call a working portal, we can place instruments and shavers in to smooth out the arthritis or clean up meniscal tears, which is another type of cartilage in there. In advanced arthritis, it basically has a very limited role. Early arthritis, a younger patient, it certainly, I think, has a role to kind of clean out or flush out the joint. Again, it's not a long-term solution like a joint replacement would be. And again, in someone with an advanced arthritis, it probably is not a good treatment option.
Now, we've just been seeing David, who was your patient, and he had his both knees replaced. Now, obviously, a joint replacement, I presume, is sort of end of the line, that's last resort, but it's curative. So how do you decide when it's time to do the joint replacement?
Ultimately, I think it's the patient who will tell me when it's time. We've exhausted the conservative measures. They're winding up taking pain medication. Their quality of life is deteriorating. They're gone from maybe where they're, can't do their activities. Now they're on a cane. They're becoming more sedentary. And they have x-rays that show advanced arthritis, and again coming back to ultimately is their quality of life is really deteriorated, and that's when the role for a joint replacement comes in.
How often do you do two at once?
Don't do it very often anymore. David was a unique patient. I say it takes a very special patient to do both in the same setting. They have to be relatively healthy. There's studies in literature that'll show if they have any significant cardiac or pulmonary risk factors, that's probably not a good idea to do both in the same setting. The other thing is, again, it takes a special patient. You get the patient that comes in and says, "Doc, you got one shot at this. I want to do them both and get them over with," because it is a tougher rehab. And a lot of times I'll counsel patients and tell them, it's like, let's do one, make sure you're happy with it. You're happy with my work, that you understand a joint replacement before going through with both. But David's done very well. He's a very good patient with us.
Mm-hmm. And now tell us, how is it done? I know I've got one of my souvenirs from my orthopaedic run just a few years ago now.
That would be a hip replacement there.
That's a hip replacement, that's right. So this little old lady had her hip joint replaced. This didn't do very well, so it had to be taken out. That's why I keep it in my souvenir collection. They're too expensive to give away, certainly back in those days. But let's look at the knee, perhaps, since David had his knees done, and walk us through what actually happens with a joint replacement.
Ultimately, a joint replacement, it's a resurfacing. Basically, you're cutting away the ends of the bones and putting on metal components, if you will, and in the instance of a knee, a plastic spacer. So in this knee model, basically, we have an arthritic joint, and that's what's being demonstrated with the ends of the bones. It's not all smooth, pearly white cartilage here. And what we'll do is we'll cut the ends of these bones away and basically resurface them. So have here basically the end of what will go on the thigh bone or the femur, and that basically is cut and is fit specially into a joint. And then on the tibia, the shin bone, is a tray that has a plastic component typically. And there's different sizes for this because it's very important to balance these ligaments on both sides so someone has a knee that's stable and doesn't buckle on them. But ultimately, it's a resurfacing. You're cutting away the arthritic portion.
So you cut bone away, put a new surface on. How long will it last?
Most will last 15, 20 years. I mean, the materials coming out now are much better than they once were. So if you're putting a joint replacement in a younger patient, that's typically what we'll counsel. Technology is amazing. It improves all the time, and some of the materials coming out are more than likely are going to be better.
Amazing, isn't it?
It is.
So, John, you rehabilitate these, or you help
Yes.
them rehabilitate. Walk us through the recovery process.
Well, from before surgery or after?
From after. They've just had this new joint put on. What happens next? So we hear David talking about getting out of bed the same day.
Right.
He's just had his bones cut off and these new surfaces magically put on, and he gets out of bed.
Well, if they have had surgery early enough in the day, and then they go to a recovery place and they get cleared, and there's a criteria each hospital goes through in which somebody gets gets covered. And then they go to recovery, and then they'll have an occupational physical therapist evaluate them to determine if they're appropriate to get out of bed. And if they are, they get them up. And that same day, they would like to actually move them out of the bedroom and out into the hallway and see what they can do.
On the day of surgery?
On the day of
later
surgery.
on the day of surgery. Wow. Things have changed.
Yes,
Things
they
have
have.
changed. Things are getting quicker. And then from there, tell us how long in hospital, and then when would they be back to normal, typically?
Well, typically if somebody goes in, let's say on a Tuesday, the idea is that they would be in for 2 days and they would be discharged on a Thursday. That home care would start on Friday morning. Nursing would be out in the morning to do the admission, and then therapy would start in the afternoon. So it's fairly quick as compared to what it was 10 years ago, when I remember someone had a joint replacement and I was seeing them usually a week down the road or 10 days or sometime even farther than that.
So are there factors that can enhance recovery?
Absolutely. If we're talking about prehab, then what clearly the research is demonstrating that if we work with someone so that they are stronger before they go into the hospital, both from their particular joint, whether it's a hip or a knee or a spine, and then holistically, from a cardiovascular standpoint, from an aerobic capacity standpoint, and if they're emotionally ready for the surgery, and if their family dynamics, they're ready to come out of the hospital and to go back home. If they have all those things done, then it speeds up recovery and their outcomes are better.
So you're strengthening muscle, you're trying to get mobility, giving them confidence and putting all of those things in place, then they will actually surgically recover faster. Is that what you're saying?
Yes.
Yeah. Yeah.
If you address both physically, strengthen the joint, strengthen them as an individual holistically from their wellness standpoint, if you help them emotionally be ready for this, that they've gone through this process, if their family dynamics are such that they're prepared to come back out, if their home has been prepared, a home safety assessment, the durable medical equipment, if all this management side of it is taken care of, then their speed through the process is faster, that their outcomes are better, and their cost in the system is diminished.